dear colleagues, you can imagine what an honor and privilege it is for us today to be here in front of you, particularly after such an overwhelming introduction. My friend here promised me this morning that I will have the first word and the last word. So that's already not bad.
And in between it's me.
Yes, because as you are aware, this is a mainly surgical topic which we are going to develop, and I'm a prosthodontist, so my part will be significantly less important. I will just intervene when I can show what I can contribute to the concept which will be developed and presented today in front of you.
Yeah, the topic, early implant placement. It's one of the treatment options we have when we have a given patient Monday morning in the office where a tooth has to be removed, and we think about what kind of treatment we could offer to that patient. And we will show you that we not only use this option, it's one of the options you have available, but I think it's important to go for a very precise case selection to do the right thing in these kind of patients. We bring you the regards from, also greetings from Switzerland. This is my hometown, Bern, Switzerland, the capital. Not far away from the top of Europe, that's the Jungfraujoch, the highest train station in Europe on 3,500 meters, and with a unique old city, UNESCO World Heritage going back to the 12th century, beautifully maintained.
This is the little city where I'm living now since more than 30 years. I'm originally from Zurich, as you heard, but this is the university which hired me, and it's a very pleasant little city, and I started to really love it. And we were sharing also the mountains between us, and he left me the Matterhorn, and I'm very happy because it's a little bit closer to Geneva than to Bern, but it's still a very great place to go to Zermatt.
I always make the point when people from the States come to Bern, I said Matterhorn is just 2 hours, so suburbs of Bern, because there is a rapid train through the Alps. And then when you want to go to Zermatt, it takes you exactly 2 hours. And then you have the most amazing mountain. You have it here in Florida as well, but it's of course a fake. We have the real one, which is millions of years old, and it's an amazing mountain to see once in nature. It's on a bucket list of everybody, I guess. Okay, then this is the house we work together now for 5 years. So they retired him in Geneva, and then I took the opportunity to advertise him to come to Bern now on Tuesdays. And he's treating patients, and I can tell you, it's amazing to see the quality of work he still provides, you see. And the postdocs love it to go and observe and learn from the master of aesthetic implant dentistry. If you want to have a handout of this lecture, which we put together first time in this dimension, then you just send an email to our CE department, and then you get, by next Monday, you get then the download link to take the whole lecture down, because we show you a lot of publications, and then you can look it up.
Just 2 words about my background. That is where I come from. I was just graduated when the gnatology was very strong, and you see a lot of famous people on these pictures: Harry Landin, Peter K. Thomas, Arnie Lauritsen, and of course on the right, this is Peter Scherer, my mentor, who brought all these famous American clinicians and researchers to Switzerland and exposed his graduate students to them. And when I look at the picture to the left, I was so proud when I first was able to manipulate a pantograph. And then I heard later from Morten Amsterdam, which I know is very close to this group, that he said, you don't need a fully adjustable articulator. What you need is a fully adjustable brain. And I digested this in time, and I think he probably was more than right. Did you recognize also somebody else on that picture? That me as a graduate student 40 years ago. See, I was very dedicated and listening what I was told.
This has changed in the meantime, yeah. He's not listening too much anymore. Okay, our history of collaboration started in the early 90s. In the early days then we had a lot of encounter with David. You see, we are both convinced team players. I've never done a single crown on an implant in all these years, and probably Urs has never done an implant surgery in all the years, because we believe if you team up, the synergy brings you higher up, and you can go to the top. And I think this setup has helped us a lot. I'm personally a Swiss oral surgeon, which is somehow a mixture of a perio surgeon and an American oral surgeon. It's in between. It's a specialty for dentists. Very active still, treat about 150 patients a year because I love to treat patients. And we are very active in research, as we said. And now, since we are together in the same building, we treat a lot of patients, mainly in the aesthetic field, of course. We treat a lot of failing implants, aesthetic disaster cases these days. Some of them are flying in from long distances to take care of the disasters other colleagues have established. Okay.
This is the menu of this next hour and 20 minutes. A rather large introduction, and then we will discuss in detail the treatment options in post-extraction sites, particularly developing the selection criteria. We will mainly focus on anterior single tooth replacement. Then the major part of the presentation will deal with early implant placement with simultaneous contour augmentation and GBR. So you see all surgical.
Yes.
Yeah.
Then we also talk briefly about contour augmentation in other clinical settings, also failed implants, just to show that this technique is really very powerful. And then, of course, we come up with 6 conclusions, number 1 through 6.
Yeah.
And I'm sure you're going to love it very much. So the introduction is that we are in a phase of routine since about 2000. We do a lot of baby boomer patients. Average age of our patient pool is about 61 these days. We do mostly partially edentulous patients. And the success and survival rate in our group is very high, very well documented. But, and that's a little bit the negative point, we see, as many others, that the rate of complication in the field is rising. And we see sometimes real disaster cases, and as we'll talk about it as well, most of these complications are caused by incompetent clinicians, and that's why education is so damn important. And I think, I'm sure we have a discussion then also on that point. See, when we go for implant placement post-extraction in single tooth situations, I want to show you these 6 cases. That's a portion of the cases I treated last year. They're all new cases I have seen last year, and we started to treat them. Some of them are finished, others are still in progress. And what we learned in the last 15 years, timing is extremely crucial. And we will come back to these 6 cases then another 2 times.
Okay, just a small introduction what the population expects from us as members of the dental medicine field. We are expected to promote and maintain long-lasting oral function. That's very trivial. This has always been like this. The key decision-making parameters which we should respect, also nothing new. We want only to implement treatments which we know are predictable. We try to be as conservative as possible, low risk for patient and ourselves, and ultimately also time and cost efficient. In the field of implant dentistry, we have to add another decision-making parameter, which is ease of reintervention. Even if we try to do our best, always keep a door open and make it easy to correct if something would not work. And this is best summarized with the words of efficacy, effectiveness, and efficiency. And in the hierarchy of a treatment plan, the most important is to do the right thing. That's efficacy and effectiveness. Once we have decided this the right choice. Then, of course, execution has to be perfect, to do the thing right. And finally, we try to do it as economically as possible. That means in time and cost. So it seems trivial what you see here, but this is always nice if you have it in your head. When you have just decided a treatment plan, just wait 1 minute, look, did I really try to get the optimal combination of what is written here? Then we are almost perfect members of the dental community. Just an example, a clinical example, what modern implant dentistry can provide, also from aesthetic point of view, the young patient with congenitally missing lateral incisors, and we try to implement what has been published over the years in a clinical result. Of course, implementing implants, but also doing very conservative modifications on the adjacent natural teeth, always aiming at creating harmonious soft tissue contours and balanced relative tooth dimensions. And here I have to give a lot of credit to David Garber. Years ago, he stated, make the artificial look natural. And so you always find the right words to describe something and create optical illusions. That is true. And here we have an example which perfectly fits into that. If everything works for us as we want, then we have maintained peri-implant tissue health, no open embrasures, no black triangles, harmoniously scalloped and convex soft tissue contours, and again, balanced relative tooth dimension. That means length to width ratios. This is during the treatment of that patient.
Are you banging on this?
I'm banging, or what?
I think that something is.
Or it's this one here.
This one.
Ah. I'm sorry. Better now?
Yeah, we'll see.
Okay. Good move. That is for a long time that we know we would like to have an excess of keratinized tissue before we do the re-entry, and then ultimately it's quite an easy procedure to come from the left to the right. Here just an example how successful contemporary implant dentistry can be. This is a 25-year follow-up.
That was our first patient we treated together in '92.
So far, I have only shown you anecdotal examples of nice treatments. And we will try now to back it really scientifically up and give you the numbers, the long-term numbers, which are behind this concept.
Okay. So when we talk about that from a surgical point of view, the first 3 points are actually what he already explained. It's interesting to see when a Swiss explains Americans' English terminology. I have to learn that as well, you see. But I think the primary objectives are clear. Successful outcomes, high predictability, low risk of complications. But of course, patients are also asking for other stuff. And we are listing the least number of interventions, also surgeries, minimal morbidity, minimal pain, short healing and overall treatment periods. We call them secondary objectives of therapy. And that's why it's a hierarchy. You see, when we changing our, let's say, our procedures, fine-tuning them, they should not alter the primary objectives. We want to maintain the top level of successful outcome on the predictability. It's very important, I think, to keep that in mind. We have made enormous progress in the last 15 years with the secondary objectives, and you will see that. When we analyze the factors that will influence the outcome, then we refer often to this ITI treatment guide book from 2008, where we came up with these 4 circles. And you see that one of the circles, see the surgeon, when we talk about post-implant, as post-extraction implant placement, is larger than the 3 other ones, because it's most important, the surgeon, for a successful outcome. And the surgeon is analyzing the patient to establish a risk profile. Then the surgeon will offer the patient, based on the anatomic analysis, the treatment options or the treatment planning. And he will pick the biomaterials necessary to achieve the primary objectives. And therefore, the surgeon is really imperative for the success That's why it has a green circle here.
Just
And yes?
Yes, there is still a little bit of room on the right. I
Yes.
hope to find there the word prosthodontist.
No,
Or at least the screwdriver.
No, look, we are talking here about post-extraction implant placement. You could do the same for an aesthetic restoration, the prosthetic field, or we could have another one on sinus grafting, but I think this is just a surgical slide here, you see. But also the point, very important, you see, that you see very clearly that the surgeon should be well educated, of course skilled, and should have enough experience to take the challenge of a given situation. 5 implants a year is not enough to go for, let's say, most complex type of procedures. Okay. I explained already why it's so important, the surgeon, you see. The treatment planning is all based on a preoperative analysis and case selection. And I often say to patients, you see, to pick the right surgeon is most important for the patient, or in other words, the clinician is often the biggest risk factor for the patient. When he gets into the wrong hands, then it can be a disaster, and we see many of these examples lately. Okay, ITI came up with this concept of SAC. This is simple or straightforward in English, then advanced on complex. It should help the clinician to understand how difficult a given situation is, how difficult the procedure can be. And then, of course, we try to appetize the clinicians to stick to their own ability and only go for the treatments they can do based on their education and experience level. So that's a very important concept and helped us a lot. I showed that 2 years ago, and I realized at that time Morris loved it a lot, because I said, the field of dentists, the field or market of lawyers, the market of teachers, it's all the same. This is a bell curve. We have top teachers and we have very poor teachers, we know that. It's the same in the dental field. So we have the low performers, the average performers, and the high performers. And I love to show, to name this average performer that he's Dr. Joe Average. And then we have the Dr. Henry Specialist in honor of Henry Salama. And then we have Dr. Jimmy Malpractice. I don't know any Jimmy in the field. But I think it's important that we as educators, and we're going to talk about that, I just talked with Howie about it, you see, as educators, we have to provide treatment protocols that can be mastered by Dr. Joe Average. We cannot only show the stuff that works in the hands of 10 people in the world, because that is causing a lot of damage. Therefore, we have a lot of responsibility to really talk about that very openly, and we have to give them selection criteria to do what. Okay, that was our introduction. Now we go into the post-extraction situation. As we said, these are all the options we have. In our lecture, we're going to talk mainly about the post-extraction implant placement. We'll not talk about socket shield technique. This is one of the topics this afternoon. And we only talk about anatomic risk analysis. What situation is present in a given patient? This was based on this aesthetic risk assessment provided in 2 ITI treatment guides, one in 2006 and most recently an update on it with one added parameter, thickness of the facial wall. This is 2016. Okay, and when we go back to the 6 cases I showed you, I show you how I analyze these patients to figure out what would be the best approach in this given situation. And I don't want to discuss it in detail, it would be too time consuming, but here you see was a root remnant. We took a cone beam and we find a very thick facial wall. Then here we have a cross section that shows nothing on the cone beam, there's no wall left there. And the third one shows an intact wall, but only about halfway up, and there is a huge defect here due to a fracture in the root And then you have another one that shows again no visible bone wall in that extraction site, as in this tooth. Then we have one with an extended apical lesion. Quite often you see that one that destroyed the whole. And then the last one is even more, so you see that's like a cystic lesion. The whole alveolar ridge is destroyed by this chronic, ongoing problem, you see. And based on that analysis, I try to explain to the patient what would be the best for you. We will come back to that. And that means, you see, as a take-home message, every case is different. Case selection is a key, see. And I really think if you want to offer the whole spectrum of treatment options, you need to have a three-dimensional radiograph. Also, good quality cone beam image is a must today if you want to go for these demanding procedures. And ITI has discussed this issue for 3 consensus conferences, 2003, 2008, 2013. And you see, came up with these categories. You see, type 1, 2, 3, and 4. We call them immediate, early, or late placement. Was published in 3 issues of CHOMI. And in aesthetic sites, we only use 3 of them. We use either immediates, same day. We use early at 4 to 8 weeks. I don't like the term delayed, because delayed could be 1 day, could be 1 month, could be 1 year, can be 10 years. All is delayed. But early is clear, that's early phase. And late is defined as 6 months or longer. And this is the original Bronnemark-Schroeder approach. See, then we have a new one. And I'm very curious to see today, this afternoon, if the boys perform well here. What are the selection criteria for them to go for this one? I tell you frankly, we're not using it not yet. We are sitting on the sideline and watch. But we will have some talented young guys to go into that field soon, very selected, and start to build up our own experience. That's no question. That's the same how we are doing with immediates. Okay, so we talk only about this. We have published last year, I think, a very nice review paper that really presented the whole knowledge at that time. And with that one, we want to give you how we think. From a surgical point of view, we want to have these 3 principles satisfied. Restoration-driven implant placement, in particular the axis and the orofacial position, most important. Implant must be embedded in healthy bone. We need to have a thick facial wall. And as you can see here, very important, we want to have the peak of the facial wall as far coronally as possible to support a nice bulky soft tissue to get there, then a nice convex soft tissue architecture. And of course, the axis is another very important point. And here the prosthodontists, they want to have an implant in a correct axis, and I fully support that because it helps a lot. The third point is not so important, that's that we have keratinized mucosa, because most often we have it. It's much more difficult sometimes in the posterior mandible. Let us talk about the axis, and you can take over.
Yeah, just a short repetition what we expect as being correct 3-dimensional implant positioning. We divided, or you, that was actually your statement, the distinction between comfort zones and danger zones. Everything which is in green, we would like on all 3 planes that we stay in the green area.
And that's the platform, huh? Yeah. Platform must be in the green zone.
Is the reference, yeah. And axis is, of course, part of it as well. And sometimes we see clinical situations which we can just not imagine how you could place an implant in a position like this. So, 3-dimensional implant positioning is important, axis is important, and also to maintain or to recreate a buccal bone plate. And here I don't need a cone beam to know that there is no bone on the facial aspect of this implant. And I have little sympathy that today in a young patient with a very thin mucosal phenotype and gummy smile, to place an implant in a way like this, because we cannot fix that. We all know that. This implant has to go again. So the key factors, they are the same as they were many years ago. And as a prosthodontist, and you will see a lot of these restorations done in the way you see on this slide, for single tooth implants, I like to be on the right side of these two possibilities. I want to have a one-piece, directly screw-retained restoration. And this asks for an easy access to the screw. And it should be located in a way, that's why this comfort zone is very narrow. You don't want to create a huge cingulum volume, and you don't want to interfere with the incisal edge. It's as simple as that. And look also at the very slim profile I think we should give to the D part of our implant restorations, and you will understand a little bit later why I'm insisting so much. The left arm, which is a 2-story building, I hardly never do it because it is complicated, it's vulnerable, and no ease of reintervention is possible if we should modify later
and
down
expensive.
the road. Yeah.
And expensive,
yes, of course. This case we will show in detail later on in our presentation, which just sums it up. If the axis is wrong, everything gets complicated, and here, of course, also this huge recession which was provoked by a two-facial implant positioning and a wrong axis.
Okay, I'm sorry, we go one back. So the implant in a correct position, and then the bone volume, a facial bone wall. That's very important for the soft tissue support. And when we go for simultaneous GBR, we need to have a two-wall defect to provide a predictable regeneration of the defect, you see. And when we analyze these cases, and we have learned a lot in the last 15 years about ridge alterations, what biology is doing when a tooth is pulled. We can have a thick facial wall, we can have a thin facial wall, or we can have no wall, thick of wall, because of an infection there. And I think that's very important, and we learned from these papers by Araujo that actually the bundle bone resorption eats up a lot of the bone when the bone is thin. That's a biologic phenomenon. Now, these studies by Araujo have been in the beagle dog and in the premolar of the mandible. That's not a very significant site for an aesthetic zone. That's why we decided then in Bern that we should have a study which actually documents what's going on in the aesthetic zone. And this is probably my top collaborator I have in my department, Vivian Chapuis. And she's very skilled and very knowledgeable. She spent 2 years at Harvard in a bone biology lab and learned a heck of a time about bone biology. And we have had 39 patients in this. We took a tooth out, took a cone beam, and 8 weeks later, same cone beam. And then with digital technology, we have been able to document bone loss or no bone loss or just a little bit of bone loss. Red is a lot of bone loss. And we figured out very quickly that there is a difference between thin wall and thick wall. And that can be shown with statistics. You see, paper was published in Journal of Dental Research, which is extremely difficult. And this study shows very nicely that a thin wall phenotype in the middle of the socket loses sometimes 7, 8, 10 millimeters within 8 weeks. It's all osteoclastic activity. Whereas a thick wall loses only a little bit, but it still loses about 1, sometimes 2 millimeters. And why is that? You see, as I said, it's the bundle bone resorption, and you see here beautiful histology from our lab, and you can see when you have a thick buccal wall, that the tip of that buccal wall still is bundle bone. When you pull the tooth, then this portion of the alveolar crest is resorbed anyhow. And you cannot stop it, it will resorb. And therefore it's so important to know about it. So the take-home message is bundle bone resorbs, irrespective of what you do. You can pray 5 times a day, it will not stop it. This is something that takes place for millions of years because it's a genetic coding of the cells. And this biologic phenomenon you better understand. This is very important. How often is it thick or thin? The problem is that we have a lot of thin phenotypes in the bone wall, because there are 4 papers on cone beams, one from Bern, but the others from South America, North America, Asia. They all show the same. The dominance is the thin wall phenotype, and that, of course, is a problem. It's much better for the first and second premolar sites. That's the beauty. So that means when you have these kind of cases, you have to compensate for this resorption if you want to have a facial wall. Okay, so when we start with immediate placement, same day, we have had in 2008 the first systematic to look at aesthetic outcomes. Now this is 10 years ago, the studies were done 15 years ago, and of course you have to acknowledge that we have seen at that time, also Uli Grunder, a lot of these kind of disaster cases. They didn't know how to do it, and they did not have case selection. They just put them in all these patients. And the study by Stephen Chen and myself, they have shown these were the studies with these aesthetic parameters. And you see here high numbers of frequency for these mucosal recessions. And the take-home message here is if you apply immediate implants without any case selection, then you are running a high risk to get recessions. That's very important to know. So when we analyzed then 5 years later, the results have been much better. And based on that one, ITI then came up that there are inclusion criteria for that. And that's an intact socket wall. We said to be on the safe side should be thick. And it should be without acute infection in that site. And based on this, we have come up with these inclusion criteria for the 3 different placement protocols. So when we talk about immediate, very briefly, I want to give credit here. We have had a fantastic stay in New York with Stephen Chu and Dennis Tarnow. It was in early April, almost 2 years ago, with my daughter, with Ramona. She's a prosthodontist. She was trained by Urs Belzer in Geneva for 5 years. Now we got her back to Bern, and they showed us how they do that. And I'm very curious, he showed me 3 surgeries, and one of them he will show us today, the 18 months follow-up. That will be very interesting to see that case. So coming back to Bern, you see I said we're going to move now. We do the immediate approach, flapless, but computer-assisted. That was my decision. And since then, that's 18 months, I found 10 patients only with these strict criteria. Of course, we were starting very careful, and we might expand now. I can tell you, the cases have done very well, 10 cases. And I show you only this one I did with Ramona. You see computer planning, digital everything, surgical stent to have the implant in a correct position, and then flapless extraction, flapless implant placement. Here as an example, you see with a guide, first spiral drill, drilling in the air, second spiral drill, drilling in the air, no contact to any bone walls. The third one then finally grabbed, and then I decided to go for a large diameter implant to have a better contact. And then we had a very good ISQ value. You see, it's a 10 millimeter bone level implant. And then, as we have seen, we produced the chairside provisional and did an internal grafting on both sides, actually, in this case. And here you see then what my daughter has done, and this is the 10 months follow-up with a very nice result. And the results that have been restored so far, they look all the same. Now, that's not our topic, but I just wanted to give credit to Dennis and Stephen and thank them again for this wonderful day, including a fantastic dinner with the family too. Okay, so the short-term experience, very positive, but I'm a very careful guy. I want to see at least 5-year data. We go into a prospective study now to build up, evidence for 30, 40 patients. That would be great. Why I'm so careful? We have some data that shows tissue alterations after 3, 5, 8 years. Now here, of course, this is from Joseph Kahn. This was no grafting at all, so we cannot count that. This one here is actually with the grafting, flapless. This is a Belgium group, 5-year data, not really good. 8 out of 17 showed recession, published a year ago, but no inclusion criteria. They said an intact wall. So they had thin walls, thick walls. It would have been great to see which ones had a deterioration, whether the thin wall phenotypes or not. So I think therefore we have to be careful with this approach and pick the cases very carefully to do it. It's a great approach for patients because it's flapless, minimal morbidity, and so on. So when we go for early placement, that's what we have done many times. You see, this is a paper with Urs Belzer and Stephen Chen. This was published 10 years ago as a case report. I'm going to show you 2 patients in detail. And this one I show you as an animation video, not a real one. It was transformed by a Spanish group into animation video. And we do first the flapless extraction. The goal of healing, get an intact mucosa, increase keratinization, increase the thickness of the soft tissue, and get the bundle bone resorbed. So the osteoclasts are gone when I do the surgery 8 weeks later. And this has always a 2-wall defect because I can measure the width of the crest at extraction. I know 8 weeks later will be the same width present. There is only the buccal plate resorbed most often, and then we can put the implant in, have a 2-wall defect, and this is most predictable for augmentation. And when you see here,
incision using a microblade. The gingival margin is carefully mobilized with a fine periosteal elevator. The extraction is carefully done with a rotational movement. The socket is debrided to remove the granulation tissue. Then a collagen plug is applied for the stabilization of the coagulum. The socket is then healed by secondary granulation.
Ze hebben nog 100 slecht, minder 50.
During the 8 weeks of socket healing, keratinized mucosa spontaneously forms over the socket.
So
The crest.
here you see another paper by Vivian that shows the thickening of the soft tissue.
However, the ridge contour does not change at the adjacent teeth within a 4 to 8 week healing period. This frontal view shows the resorption of the thin facial wall triggered by bundle bone resorption. This causes a crater-like defect in the middle of the socket. The sagittal view shows the facial bone resorption and the ingrowth of soft tissues into the alveolus, leading to a spontaneous thickening of the soft tissues. This is biologically driven and is a clear clinical advantage for the future implant surgery. The coronal view shows the resorption of the facial bone wall and the spontaneous soft tissue thickening.
That's the flattening you see in these kind of cases in the middle of the socket.
Takes place in the middle of the socket.
Now, you see, it heals, you get the soft tissue formed, you get the keratinized mucosa, and you get this soft tissue inside the socket. And then, of course, it's important that you use an incision technique in the mid-crestal area that goes slightly palatal to pick up all that soft tissue to have it as part of your buccal flap when you do the implant surgery. And we are using, and that will be another discussion with Dennis, that's an only disagreement I think we have. We are not using papilla-sparing incisions because when you add contour here a lot, then I want to have a large flap that will not give us any risk for scar lining in this very critical area. So we learned from Uli Grunder and other Italian guys 10 years ago, I made the move that a triangular flap gives us the best chances for contour augmentation. And you see, here you see the animation again, how the incision is done.
8 weeks post-extraction, implant surgery is initiated with a sulcular incision at the adjacent central incisor and extended in the edentulous area in a slightly palatal position. The blade is inserted deep into the remaining socket along the inner palatal wall. The incision is continued through the sulcus of the adjacent lateral incisor. combined with a papilla base incision and a vertical releasing incision at the first premolar. The result is a triangular flap which offers excellent vascularity and eliminates the risk of a vertical scar within the aesthetic frame. The mucoperiosteal flap is now carefully elevated with a fine tissue elevator. In the extraction site, the soft tissue within the former extraction socket is mobilized as part of the buccal flap. This provides a thick, soft tissue biotype in the future implant site. The surgical site is exposed and irrigated with sterile saline.
Okay, that's amazing, this technology. It was done by a Spanish group in Madrid. And you see here Our Lady, where we have done this incision, slightly palatal with a microblade, and you see here the thick mucosal margin, the thick flap in the future implant site, and you see that in more details, and you see here, of course, you get a thicker flap. I don't do any connective tissue grafts for more than 10 years in such cases. I use it most often, soft tissue flaps, connective tissue grafts and full thickness grafts in failed aesthetic disaster cases to get keratinization back. So in routine, we don't use these connective tissue grafts anymore, you see. And then we put the implant in a correct position. We talked already about it, you see. Very important that the implant shoulder goes subcrestally in a correct dimension. And here you see how you can do that in a single tooth situation. I don't use surgical stents in a single tooth situation, use a perio probe and orient myself. When we have multiple, then I go for a surgical stent always, because then I don't have all these landmarks available from the neighboring teeth. Okay, the goal is, you see, to augment the bone. And what we do now since 2005, when we got first these bone level implants, which is a platform switching implant, we add here actually a 2 millimeter healing cap, at least, sometimes a 3 millimeter healing cap, to extend the implant further up, and then to perform here and contour augmentation to the rim of the healing cap, and not to the rim of the shoulder. That gives you extra bone formation, and the goal, as I said before, is that at the end, when everything is remodeled, we have a situation like this.
That's why it's so important that with the first temporary, we are very slim in the deep, that we are not disturbing the continuous healing of that part which is placed against the healing abutment. That's because I see sometimes that technicians want immediately to have the right emergence profile, and then they get into a conflict with this structure.
Now, another detail here is the subcrestal positioning of the implant shoulder, because this implant has a selective surface all the way up. I want to have this fantastic surface inside the bone, not supracrestally. That's one of the major reasons for peri-implant infections these days, that people are putting in implants everywhere but not inside the bone. And therefore you have subcrestal position here, here and here, and on the buccal you build it up and have it also then inside the bone when you are successful with this formation of the regeneration of a facial wall. So the contour augmentation, which is now 20 years old in this scenario, I will show you that case. The first one has a 2-layer composite graft. We know composite grafts for years in the sinus grafting area. You see, there it's mixed, but I use it in 2 layers for contour augmentation, and I will explain to you why I use autogenous bone as a biologic filler, and the DBBM, which is BioOs, as a filler to maintain the volume. See, here is the critical part.
For the next step, blood is harvested with a syringe and stored in a sterile dish.
That is done just after flap elevation, as first measure.
Now, autogenous bone chips are locally harvested within the same flap from the cortical bone surface. This can be done with a flat chisel at the nasal spine, or with a sharp bone scraper from the bone surface towards the nasal fossa. The resulting bone chips are 1.5 to 2 millimeters in size, and they are stored in the blood.
Now it's important, these chips are always harvested within the the same neighborhood, same flap, not a second flap. We changed that 20 years ago to reduce morbidity. So it goes into the blood bath, you could say. This is blood and ringer solution 50-50 or so. And then we have done a lot of research with our cell biology guys. I don't understand 20% of the basics of this research because it's cell biology, very basic. But of course, for that, we hired these guys for our group, paid a lot of money for their salaries. And you can see here all the publications in the last couple of years, and some of them in top journals. I want to show you the latest one, which is not accepted yet. It's in revision right now in International Journal of Oral Science. Maria Asparuova, that's the latest. She is the head of the cell biology lab. So you see the bone is harvested, and then we add here, you see either ringer solution or ringer solution and blood. That would be the clinical scenario. And then you go into cell cultures and see what this is doing to the environment there, you see. And I will not explain in detail what she tells us because that's her business. But when you summarize it, you can say, and this is amazing, that you have already after 10 minutes, you have a fast release of TGF-beta-1, which is a very most important growth factor for the proliferation of cells into the defect. And slightly later comes then BMP2, which is another very important growth factor, as we all know, in osteogenesis. So when you summarize that, you can say, you see that this mixture here, we call it bone conditioned medium, published on BCM, contains a lot of TGF-beta-1 and BMP2. This explains why we have seen so fantastic results with autogenous bone in vivo studies in animals. With Bob Schenk, mid-90s we started. That's 20 years of research, I think 8 publications so far, some of them very highly cited. And I show you 2 of them. You see, we measured this histomorphometrically. And here you see 2 papers by Simon Jensen, osteogenic potential and substitution rate or volume stability. And it repetitively showed the same. There is only one filler that stimulates bone formation, and this is autogenous bone. And you can see that here. This is 2 weeks, 4 weeks, this is 4 weeks, 12 weeks. Much faster formation of bone. When you talk about volume stability, the long-term stability of the filler, then of course bone is not performing at all well. And then you have to have something which is like hydroxyapatite, and here BioOS, also DBBM, has done a very good job. That's how we picked these 2 fillers as a combination based on recommendation of Bob Schenk. That was in 97, 98. So these were the histologies we had from a paper myself in 98, 4-week specimen. And here is a paper by Simon Jensen, only 2 weeks, a 5 millimeter defect, complete bridging in these defects after 2 weeks. That's hard to believe. So the take-home message, if you want to speed up, then you take autogenous bone. I do not believe in a single factor that can do that. Bob Schenk always said, Mother Nature is much more complex than our way of thinking. You cannot add one filler and one growth factor, then it will mimic Mother Nature. Okay. This is how it is done. You see the blood again. Now this is in a patient. And you see how easy it is. It's 1 flap for a single tooth replacement. So we mix that with ringer solution. And then we take at the nasal spine as an example with a flat chisel, has to be sharp, no mallet, very careful. Or you go to the side towards the nasal fossa with a sharp scraper and take the bone and put it in, and then you put that dish to the sideline for the next 15, 20 minutes and continue the surgery. Growth factors start to dilute, come into that blood, and so on. And very important, you see.
The blood in the sterile dish is diluted with some sterile saline to increase the volume of the bone-conditioned medium. The medium is used to moisten the bovine bone
je ziet
filler,
het.
which has a low substitution rate.
Ja, we rollen me mee over.
The bone-conditioned medium contains a lot of proteins and growth factors, which are absorbed by the bone filler particles. Bone augmentation is initiated with the application of the autologous bone.
So what you see, you have this bone, the blood, you take the blood, this BCM, put it into the bioos, and what you do actually, you activate bioos, you make it biologically active. And this was published in 2 papers here. You see that these fillers soaked in BCM, this filler became biologically active on osteoblasts, for example. That means the entire volume of your augmentation is biologically active, although 80% of the filler actually is bioos, which is not an active filler from a biologic point of view.
Application of the autologous bone chips. The first layer of bone chips is applied to the rim of the healing gap and completely fills the facial bone defect. The second layer of bovine bone particles is used to over-contour the local ridge anatomy. The surgical technique is called contour augmentation, using the 2 synergistic bone fillers of autologous bone chips and bovine bone particles.
So you have the 2 fillers.
And trim to shape.
Now comes the membrane to have a temporary barrier function. We most often use collagen membranes to eliminate the reopening procedure.
When moistened with bone-conditioned medium, the membrane becomes soft and adhesive. It can be easily adapted to the local bone anatomy. The second membrane strip improves the membrane thickness in the defect area and improves the stability of the membrane.
So this is like a bilayer application, a double layer technique.
Steps of contour augmentation.
So here you see how it's done.
And will stimulate new bone formation. The bovine bone particles provide the contour augmentation and long-term stability, since they have a low substitution.
Autogenous bone, DBBM.
The collagen membrane provides a barrier function to avoid the ingrowth of soft tissue cells.
So the next point is then to close it up. We are not using any immediate restorations in the kind of case. I want to have these biomaterials covered up, protected, and since we have autogenous bone in there, we only need 8 weeks for the healing. We started about 10 years ago to move down from 3 months to 2 months, and since then we are using that. So the 8 weeks healing period, allowing an early loading, this is a routine these days in all these applications. The reopening is easy to do.
12B blade. The healing cap is removed with a screwdriver and replaced by a longer one. Following a few days of soft tissue healing, the provisional crown is inserted to initiate the...
You see that this is a minor procedure. I think anesthesia most often is the problem for the patient. Takes 5-10 minutes. Patient goes into private office. Provisional restoration, final restoration. We will hear about that from Urs then when we come to the prosthetic phase. And here you see our patient 2 years follow-up last year. See, she's 75 years old. She's very happy now. You see the neighboring teeth, she's not bothered by them. And the implant restoration was a very bulky soft tissue here, convex, and the implant well integrated. So when we talk about long-term results, before we come to our 10-year study, I want to show you the first patient we treated in January '98. That's the case I was able to see again last Wednesday morning. She's from Zurich, and you see it was the first premolar. The tooth was removed in private office. I saw her after 6 weeks, and then 2 days later we did this contour augmentation. This is a Straumann tissue level implant with a TPS surface at that time. You see crater-like, quite significant. You see the bone, the DBBM, the collagen membrane, and the primary closure. You see then the reopening at 3 months at that time. Here, 5 years follow-up. Crown was done in private office by a colleague, a GP. And here is now the patient at 20 years, last Wednesday. I was very pleased to see that she has still a little recession at the tooth. The implant is holding up beautifully. Periapical looks just normal. And the cone beam shows a beautiful, intact buccal plate with this technique. Then another 10-year case, that was the patient we presented in 2008, same technique. Now this is now a bone level implant. We favor bone level implants for single tooth cases in the aesthetic zone when the vertical bone situation is applicable. You see same technique, of course. You see then provisional final restoration. This is now done by Urs Belzer. And here you see the 10-year follow-up of this patient. Urs will come back to the aesthetic outcomes then in more details. And you see again excellent periapical and in particular the facial wall extending coronally to the implant shoulder at 10 years. And the thickness is about 2 millimeters when you measure it. So we have published of that patient pool 1-year data, 3-year data, 6-year data. Now recently with Vivian Chapuis, last November, 10-year data. It's only on EPUB available. It will be printed this year in Journal of Dental Research. And only 20 patients, you could argue, but the beauty is all of them, we have a 10-year follow-up, 0 dropout, which is of course remarkable. One patient lives in London. We flew her in to have this 10-year follow-up with her. And you see, of course, a different range of age. You see the radiographs are provided. At 6 years, at 10 years, we have a cone beam, all approved by ethical committee. And when we go into the clinical parameters, very stable. All implants clinically successful. None of them a peri-implant infection. All of them have very low bleeding indices and plaque indices. And you see the cone beam shows in 70% of the cases, that's 14 patients, a fully intact buccal wall and the peak on top of the implant shoulder. Then we have 5 patients, an intact wall but a little bit resorption, as a negative distance from the shoulder. And we have 1 failure in terms of augmentation. That's Mrs. M, I call her. She did not have any bone at 6 years, no bone at 10 years. So this is a surviving implant, no clinical symptoms yet, but it's not successful from terms of bone augmentation. And now I will hand over to Urs. You see, this is a case that has had a long fractured root, had to get a new crown here. You see, huge defect, was then restored. 10 years later, we have seen he will explain that to you, and this discrepancy in the incisal edge. And we had 3 cases where the neighboring tooth developed a recession and not the implant crown. Huh? That's very typical. So when you can establish a nice facial wall, the stability of the tissue is remarkable. You see the periapical, another excellent case at 10 years. And look here with this kind of defect, the buccal wall is going all the way up to the implant shoulder. Now I hand over to Urs now, who takes a longer period now on the prosthetic side, aesthetic results.
Okay, to sum this study very briefly, as to summarize, this is the 10-year follow-up, which we published also in the Journal of Dental Research. I just put in red what is the most important, that all these implants were treated according to the concept of early implant placement and simultaneous contour augmentation, and we had not a single incidence of facial recession on the implant sites. However, when you look here, that was at 6 years, also published in the Journal of Dental Research. We placed all the 20 patient pictures on the same spot after 1 year and after 6 years. And what you see now, that in this patient, number A, there has developed an incisal step. We have this on a second patient, on a third patient, a tiny little one. See, most of the others have not moved, and we have a small diastema which has developed on one of these patients. So we have now really data which shows that this is happening, and this has changed our attitude, how we communicate with patients who we think they should have an anterior maxillary implant. We tell them this phenomenon is small in size. It, according to the literature, appears in less than 10% of the patients, and it is primarily associated to the long face cephalometric morphotype, known by the orthodontists, and aesthetically disturbing primarily on central incisor implants. So, how do we communicate today with these patients? We tell them that implants will most likely stay successful for very long, mostly for lifetime. However, the implant crown or superstructure may need modification or even replacement some years down the road if it gets really disturbing. And that's why we clearly favor directly screw-retained implant restoration, so that we can modify or we can easily replace. The question which arises also, should we on younger patients postpone anterior implant placement under the light of that we see that some ongoing dentoalveolar growth is happening in some patients on the adjacent dentition. If we have a reasonable alternative, like a one-part bonded restoration, sometimes I do that. I explain the patient, we can gain another 5 to 10 years and place the implant later. However, we should be careful that we do not pay a biologic price of postponing, that implant surgery becomes more complex if this would be done later on. So this we have to discuss with the patient, and then we take our decision. But we need clearly more studies to give us a clear view on that phenomenon, so that we can eventually draw some conclusions and maybe change our strategy. But for the time being, it's that what we do. Here you see a very moderate example. If a patient after 12 years shows a tiny little discrepancy on the incisal edge, and the same also on the cervical margin, most of the patients do not really complain of that. It develops so gradually, they get used to it. So this patient in particular, she is very happy with the results, so I would not now insist and start to want to modify something on this restoration. See here, the same patient,
12 years.
12 years follow-up. And when you look at the cone beam, also look at the facial aspect and look where we came from. That's when Professor Buser placed this implant. It's exactly where this cut on the right side is done. So there were bone chips and bone filler and membrane, and look what is left of that 12 years later. So it clearly, for me as a prosthodontist, shows me that this is probably the most predictable way to prevent mid-facial recessions. Now I go to these other examples. This is a patient, she was already around 60 years old when she got that implant, and she had already open embrasures in the adjacent dentition. I don't want that I see no black triangles. If somebody has in the environment, it just has to blend naturally in the environment. And this patient was very happy with this. You see on the top row the baseline, X-ray and clinical photographs. You see after 10 years she did not develop an incisal step. Everything looks exactly the same, also the X-ray, and now the 10-year cone beam shows again what we have on the facial aspect. Here this patient who developed this small diastema. But when you look at the mid-facial aspect, when you look at the radiograph, one baseline, 10-year follow-up, and the cone beam, 10-year follow-up, it sums it up again. Remarkably stable radiological data. And the third patient of this group on a lateral incisor, I mean, these pictures speak for themselves. I see a small little fracture on the distal edge of the natural tooth, but otherwise very stable. And also look at the cone beam again on the right side.
Okay. We have a third option, late placement. There are indications where we have to wait, and that's very important to understand. And you see, there can be either huge defects, we cannot stabilize an implant, can be a young patient, too young. And I can tell you lately, I'm doing more and more late placement in elderly patients, age 80 plus, to minimize the trauma of the surgery then 4 to 6 months later. And here you see just one example that has one of these cystic lesions. We have published that case in an ITI treatment guide. First a cystectomy, then here a ridge preservation technique, and then 6 months of healing, and then we put the implant in, and you see 2 months later reopening procedure, and then here you see the restoration with the 6-year follow-up. The implant is slightly deeper as usual because we have had a reduced palatal height of the bone wall, and the cone beam shows an excellent facial bony support, so that really helped beautifully to maintain these nice peri-implant soft tissues. Another one is young patients with ankylosis, and this Urs will explain.
Yeah, she's in her mid-20s.
No, she was at that time, she was 16 in the beginning. Very young, yeah.
But when I treated her, she
was
22.
I saw her with 16, so she
Okay.
was waiting 4 years to get the hands on Urs.
Okay.
Yeah, or vice versa.
Anyway, we were quite worried because we have a very irregular soft tissue course, and one would expect because we cannot do orthodontics here on that side, and we cannot easily extract that tooth, so that we were worried. And to make a long story short, what we decided at that time, that if the patient would accept, I took an alginate impression to make a removal partial, and on the next session I reduced as much as possible the volume to give a maximum of space for the soft tissue to grow in over that root. You see, the patient had to accept to leave the office in this aspect, and she was a good sport. She says, yeah, if this is beneficial for the result, I do that. We saw her again 3 weeks later and removed a little bit more and waited another 2 weeks.
That's the Burden-Langer technique, published 94. We all know it.
And then Danny opened a small flap without elevating the papillary region. He split orofacially, and he removed very gently these ankylosed root halves. And then it was ridge preservation technique.
Ridge preservation,
something just, you put material in there.
Yeah, bios.
Yeah. And the primary wound closure, and you see there the patient 10 days later on the very right. And then we waited another
6 months.
6 months.
Then the surgery.
Then an implant was placed, and this is the moment, again, 6 or 8 weeks after implant insertion, we took an impression, and this is the temporary restoration. Document, you see the blanching, it was just taken at the moment of insertion. And here you see now the summary, how we started, what we did first, and then the surgery to remove and ridge preservation, and then secondly, place a new implant. Quite remarkable. Huh? So whenever you have a chance to enhance the situation from a soft tissue point of view, use this. It is always only positive. And then we waited many years actually with this temporary because we had some orthodontic complications on that patient later on, because she was treated and had no retention, and then we struggled a little bit with the final restoration, but we had ultimately now a quite stable radiographic and clinical outcome. Now, some contour augmentation in other clinical situations, and I would like to show you what we have done now for roughly 12 years on anterior single tooth implants. That's my favorite, to have a CAD-CAM generated zirconia base and then directly stratified ceramics. And we use this press ceramic Emax technique first, but there are different ways to do it. This is just a precursor of doing it fully digital, and we are very close to have this happening. See, then we just keep a little bit of space for a little bit of characterization at the end by hand stratification, then it's embedded and it is pressed. And this is, again, showing how important three-dimensional implant positioning and axis is. You see very slim singular areas and still easy access to the screws without interfering with incisal edges. Slim profile, and the technician just did by hand that characterization of the facial surface. And if we are lucky, then also on adjacent implants, occasionally we get the illusion, as David Garber said, illusion of a continuous scalloped soft tissue line. And here you see this patient at baseline X-ray and 5 years and the clinical area. So we feel quite comfortable now on adjacent implants if you have conditions like this, if you also have the space. I refer to the data published by Danny Tarnow's group. She has a gummy smile. This is a 10-year follow-up, very happy patient, and also very happy dentist. Huh? These are the days where you really like to be a restorative dentist. Huh?
He has, of course, an easy job. Huh? Yeah. He has a good surgeon. But important, I want to stress that point. Huh? Yeah. This is not a case for tissue-level implants or the old Bronnemar type, because you're going to get there a saucer. You need a platform switching implant that maintains the maximum amount of bone, and you see what you get here. This is amazing 10 years down the road. Huh? So it's all about the blood supply of that bone and the need, the maximum amount of bone in between two implants. And we know, of course, the distance is critical. 2 centros is not a big deal anymore, but a center and a lateral is still a big challenge, and there we normally use 1 implant and a cantilever. That gives us the best outcomes.
There's a second patient. Also, we replaced the 2 missing centrals. People say that we should not connect zirconia directly into titanium implants, and it's tricky, but for single tooth restorations, if you are carefully adjusting into proximal contact, I had seen not a single fracture on that one. The advantage of this is that I can be very slim. These very popular titanium bonding bases, vario bases, where you make this zirconia restoration and you use composite to bond it to that, it usually has a larger volume, and then it interferes or could interfere with this augmentation protocol of Professor Buser. That's why this is still my favorite design on anterior, and we have done more than 100 of those. And this is a patient who had an accident, and then he got 2 implants first, and then they were malpositioned. Professor Buser had to remove them and put them back. Why do I tell you that? Because this left a little bit of scar tissue. That's the only thing which actually could be slightly criticized here, but all the rest is just beautiful, and a very, very happy patient because the treatment is finished, and this is his maximum smile. So again, we see now that we have a protocol here that can really satisfy. And to underline this with a third patient, also she had an accident, fractured her 2 centrals, they were lost. Then Professor Buser places the implant exactly as you have
Can I make a point
before.
here?
Yeah.
See, as you see, the same protocol, but a little difference. Stability in the wound is most important. When we have large augmentation areas, then you can do either tacks to stabilize a membrane, or I do normally that I take a fibrin sealant for many, many years. And this, what you see here, is actually tissue cold. This is, it's called T-Seal now. It's from Baxter in the United States, a European fibrin sealant, and you can immediately coagulate this fibrin. It's fibrinogen and thrombin. And that helps us to get more stability into these augmentation areas.
And here you see what quite often we use as a temporary after surgery. that it's an Essex retainer because that's the one which we know will really make it impossible to load the surgical site. Patients hate this type of temporaries. They cannot eat with it. This is a few weeks of difficult life for the patient, but we try to convince them that it's worth it long term. And I try to prove you that with here. This is at the BISC stage of the restoration again, CAD-CAM generated, zirconia base, and then pressed ceramic on top, and then just the surface a little bit characterized by hand. And again, look at the X-ray and look at the integration of these restorations, and you can believe me, happy patient. Again, that was a good day at that time. She has a gummy smile, and now she started to smile fully again, and can hardly believe it, what has been done after she had suffered so long. And this is the close-up. Another indication, this is a patient referred to Professor Buser by a periodontist who had removed that tooth, which we can understand, and placed an implant. And unfortunately, no facial bone at the moment when restoration was planned. And so was referred to Professor Buser. You see what his decision was. This was a malpositioned implant, too far to the facial and too deep. So he opened his the triangular flap, and with the same system you have seen with the previous speaker, removes this implant. And now comes the question, just to see if you are still awake. Do we have to graft now, or can we place an implant again on the same session? You agree? He said, yes. I place it less deep, but more to the palate, so that I have the 2-wall defect, and then do the procedure as before. So he did it in the same session.
But the difference, you see, this implant was placed just with bios, about 1 millimeter too far facially and bios. Didn't work because there is no bone growth from the side in this situation. So we put it slightly more inside and, of course, opened up all the bony walls and then added autogenous bone to activate new bone formation, and then the bios. It's the whole difference. Okay.
Then primary wound closure and control X-ray, and then again, 2 months later, we started with the restorative phase, reopening, and the temporary restoration. And you remark, distal on the central incisor, a small recession. So we need a little bit help of design features. This is the parameters which we can use, just positioning of transition line angles and interproximal contour to compensate for vertical tissue loss. And this is the restoration. When you compare the natural side with the other one, it's not exactly symmetrical, but when you look at the patient at normal communication distance, it looks harmonious to me. And here is the 9-year follow-up, and it shows really it's a masterpiece from a technical point of view. This is Alvin Schönberger who made the restoration. This is just understanding the tricks which we can use to compensate a little bit of vertical tissue loss. Very nice result. And when we look at the X-ray, on the left you see the follow-up, and compare it to the pre-op, then I think you know exactly what was the difference, why we have now this stable soft tissue situation. And the last patient, I promised you to show this one. He had an implant gone too far apical and too far to facial, and it resulted in this huge recession, but he kept it for several years before he really came to see Professor Buser. You can also see that he had developed an incisal step of about 1 millimeter. This is the cone beam, just confirming what you have seen. Horrible axis, and the result is the recession. So we removed, it was a horizontally screw-retained screw. I removed this anti-abutment and then put just Teflon in it to give a little bit of space, maximum space, and this removal partial denture. And then I think 10 days later, Professor Buser removed the implant, and I don't know if you want to comment this.
No, what we do in this kind of cases, we take the implants off with this BTI system, which is a very nice system for most of the implant brands I have seen. And then we do a socket grafting or a defect grafting to have a basis for a full thickness graft from the palate to get keratinization back. We all know these days, you see, we often get a little bit scarry tissue, but we get keratinized mucosa, and that's most important. And we do that, I would say today, in most cases, at the time of implant removal. So in one surgery, flapless because of the BTI system that allows that.
Okay, then you waited.
Yeah, that is a 2 to 3 months healing period. This is from a video clip from a master course. We just did screenshots. So you see, had a quite significant vertical tissue loss also on the palatal side. That's why I had to decide to go for a tissue level implant to get the micro rough surface below the palatal wall, but have the implant show the within reach for the prosthetic treatment. And then, of course, bone augmentation the same way with autogenous bone and DBBM. Then the double layer technique with the membrane and primary closure. Here you see the post-surgical radiograph. This is a 1 millimeter healing cap on top of this tissue level implant. Then the prosthetics.
Yeah, that was also about 3 months later. Taking impression. You see how deep this implant is, although it's a tissue level implant, and that's why I think it's an important point you just made. Directly screw retained temporary, usually I keep them for 5 to 6 months. And I don't want to have more than this insertion session and one additional one to come up with the final emergence profile. Otherwise, it gets too expensive for the patient. Here, this is then the final restoration at the bisque try-in. Look again at the slim profile I tried to keep in the deep part, and then the final with the respective X-ray and the comparison between initial and final.
What you see here is often a little scarry tissue. I told just Urs when I saw the picture now the first time that I want to see the patient again, take the crown off. I'm going to take a CO2 laser and going to refresh and resurface that area. I'm sure we're going to improve the situation a little bit. But of course, the patient is very pleased. After that, he sends his wife for treatment because she's even having a more difficult situation with a 4 missing situation now. Okay, with that, we have 7.4 minutes left over. We are even on time. We have 6 conclusions. And we want to summarize, and we made it the following, that conclusion 1, it's all about biology. When you do surgeries, I'm sure we're going to hear a lot about that from our colleagues, because I think we have the same way of thinking. It's all biology. You cannot fool Mother Nature, and therefore, as clinicians, we need to understand the hard and soft tissue alterations post-extraction. Very important. Second, we also need to understand the important role of bone volume for the aesthetic outcome. It's not lack of soft tissue that primarily gives us problems, it's a lack of bone. And thirdly, we need to know the factors which will influence and stimulate osteogenesis, also the formation of bone. How can we stimulate bone formation? The second one, it's all about case selection. That will be the most important discussion this evening. In what situations can we use what? Do we agree on these criteria? So as a clinician, we need to know the various treatment options available in a given clinical situation. We need a thorough preoperative examination, and this includes a cone beam to know the anatomy in all dimensions. And also very important, the chosen treatment option should be based on anatomic risk factors and also on the ability of the clinician to perform the surgery. So when I lecture to colleagues and they tell me they do about, I don't know, 20 to 50 surgeries, and they also do aesthetic cases, then I tell them, don't do immediate implant placement. Go for the safer procedure and stick to the other one. When you're a top master clinician, hundreds of implants, you are used to do that, then of course it's no question you can. Don't come too early, huh? No, you're on time, huh?
We have still 5 minutes, 23
He creates
seconds.
pressure here. Okay, conclusion number 3, it's all about treatment quality, huh? How you perform. Huh? And that means you have to put him in the correct position, correct axis. You need to augment the facial bone wall. When it's immediately placed, it's an internal augmentation. And when it's early or late placed, it's a contour augmentation. For that, you need an open flap procedure from my point of view. Immediate can be done flapless, we know. Number 4, it's all about the biomaterials. Also the grafting material, you have to select those with a good documentation. You need to understand what you need. So we need an osteogenic filler and a volume stability filler. And that's why we combine those. Then it's all about long-term documentation. That means the treatment concept should be well documented. Of course, in the beginning you start with case reports, then prospective clinical study, then mid-term 5 years, and at the end 10 years long-term. And that's how to do that. I heard from Howie, you see that they are establishing that now. That's exactly the way to do. That's what we did 20 years ago. The studies must include cone beams, because you need to know what you have on the facial. And of course, the concept of early placement, after all these years of lots of work, I think we can say we can fulfill now these criteria easily. And the last conclusion, I leave to Urs.
He promised me.
Yeah, exactly.
So our long-term experience has clearly shown that we need to expect in some patients the need for modification and for renewal of the superstructure down the road. And so this is associated to this ongoing dentoalveolar growth, which is not a contraindication to placing implants, but we should inform the patient that this can happen, but then we should have a way out, and that strongly recommends direct screw retention and no cementation or no two-story buildings. They are really complicating the thing. And
so we come back again to that table that is in this review paper. So the immediate placement, early placement, late placement with all the inclusion criteria. And when we go now to the 6 cases I showed you, how did I treat some of them with Urs, these cases? Then you see the first one with a thick facial wall, nice bone volume, everything. I did an immediate approach. A patient was very happy. Manager, 8 o'clock surgery, 10:30, a meeting in the office. So he was very pleased. Here, no facial wall, early placement. Here, a wall with a defect because of an infection, early placement. Another one, early placement. Here, another early placement. Now this one with this cyst, late placement. It's just in a healing phase right now. As you see, we have used all 3 options, not to the same percentage. That depends on probably also personal preference, where you are in your development. But I think it shows that it's not black and white. It is all of them, and inclusion, case selection is the point to make. With that, we'd like to come to an end. We thank you for your attention. Again, the handout you can get, and we have a final personal last slide by Urs.
yeah,
Oh.
that's the nice thing about retirement. That's the best. Every Friday and Thursday I have this, and I have one more. As my children decided to not follow into dentistry, I was a little bit sad. But they are successful in economics. But now this little girl here, and because we wanted to make a last conclusion slide saying it's all about the patient and it's all about home care, There is
floss.
some talent in the Belzer
She's
family
flossing
now.
the baby already.
See? And so maybe she will get a dentist. Anyway, that would be nice. Thank you very much for your kind attention.
Thank you.
Thank you.